Coronary artery disease, or CAD. Etiology, or how does somebody develop CAD, is basically from the fatty deposit buildup within the coronary arteries in your heart. Atherogenesis is the term used to describe the buildup of cholesterol and lipids within the artery. So, HMG-CoA reductase inhibitors, or statins, this is a pharmacological class of medications used to treat cholesterol. HMG-CoA basically stands for hydroxymethylglutaril coenzyme A reductase inhibitor. So what's the mechanism of action of statins or HMG-CoA reductase inhibitors? So how it works is basically it inhibits the HMG-CoA reductase enzyme activity. So that's in the liver, right? And so that's really a requirement in order to produce cholesterol. So because it blocks that process, then it's able to reduce the level of cholesterol in the body. So based on that mechanism of action, the therapeutic effect of statins is basically reducing the rate of cholesterol production. So decrease in total cholesterol, right? And then it also can affect the different types of cholesterol. So you have HDL and LDL can be both lowered. But in general, so FYI, HDL is your high density lipoprotein, which is your good cholesterol, and LDL is your bad cholesterol, which is your low density lipoprotein. So statin can actually lower both. Some contraindications or reasons why we shouldn't give statins to certain patients. Well, one is basically during pregnancy. So this is considered a pregnancy category X. So in here, studies demonstrate that by taking this medication, there are risks for developing fetal abnormalities. So there's evidence of fetal human risk, which outweighs the potential benefit of taking this medication. Now, another contraindication is liver failure or liver dysfunction, or somebody who has elevated liver enzymes. So as we know, this affects the liver. Therefore, there is a likelihood that if somebody is already having liver problems, it can actually make it worse. So some side effects that you guys have to remember. It can cause hyperglycemia, right? Increase in sugar, myopathy or rhabdomyolysis, headache, memory loss and confusion, and gastrointestinal disturbances, as well as liver dysfunction. So with hyperglycemia, it is really not clear as to why this medication causes the increase of sugar in the bloodstream. So it is believed that it does affect the insulin production or insulin sensitivity to the body. Now, myopathy is actually a very common complaint. So myopathy is basically muscle pain, muscle aches. This is a common complaint by especially the elderly who are taking higher doses of this medication. So sometimes the myopathy can be prevented if the patient just takes a lower dose instead, and sometimes just changing the agent or the medication itself. Now, rhabdomyolysis is actually quite serious. So rhabdomyolysis is a life-threatening side effect of statins. So if a patient develops that, that's actually an emergency, and we need to make sure that the patient seeks medical help immediately. So what happens in rhabdomyolysis is actually it causes direct or indirect muscle injury by releasing of CPK, which is very damaging. It also releases myoglobin and protein, which can cause kidney failure. So a symptom or signs and symptom of this include the dark brown reddish urine when a patient has rhabdomyolysis. Some nursing actions when a patient is taking statins. It is very important to educate them on when to take the medication. So for statins, the ideal time to take the medication is actually at night, because at night it is when most of the cholesterol is synthesized when dietary intake or when we're not eating. Now, definitely we need to assess and provide patient education. So assess the neurofunction, muscle weakness, blood sugar, right? Because we know that it can affect the blood sugar, and also GI symptoms as well as urinary changes. Also, as you may remember from previous units, just be very careful if patient states that they drink or eat grapefruit, right? Because it has it interacts with grapefruit. So again, grapefruit contains a chemical that interferes with the body's ability to metabolize certain statin medications. So what happens is it increases the statin in blood levels, and so it can cause some side effects and even toxicity if we don't intervene. Examples of drugs in this class. So what you need to remember are your prototypes, or the generic names of your prototypes, which is for here is atorvastatin and simvastatin. Next are your bile acid sequestrants. So bile acid sequestrants are actually second line after the statins, or are used in conjunction with the statins. Mechanism of action. So what it does is it binds to bile and it's excreted in the stool. So bile aids in digestion, right? So it increases absorption of fats and fat-soluble substances, and the route of excretion for bilirubin, a byproduct of red blood cells recycled by the liver. So in addition, we have to remember that bile acids are necessary for absorption of cholesterol from the small intestine. It is also synthesized from cholesterol by the liver. So this medication actually prevents reabsorption of bile acids from the small intestine, therefore lowering the cholesterol levels. Therapeutic effect of bile acid sequestrants include decrease in total cholesterol, and it may affect individual types of cholesterol such as the HDL and LDL. So contraindications for bile acid sequestrants. One contraindication is biliary or bowel obstruction, as well as PKU or phenylketonuria. So PKU is basically the buildup of amino acid phenylalanine in the body, and then so this is actually a metabolism disorder. So if you know that the body cannot really process amino acids and there's a buildup, and this medication is really not the medication for those kind of patients. And as we know, the way it gets rid of the cholesterol basically is through excretion from the stool. And if you have somebody with problems with digestion or bowel obstruction, then the medication is not going to be effective. Examples of drugs in this class include, what you need to know is Questran or cholestyramine, Welchor or colicivam. Next is your fibric acid derivatives or fibrates. The therapeutic effect of fibrates include basically primarily lowering triglyceride. Also, it may affect the total cholesterol, but mainly it lowers your triglyceride levels. Indications or reasons why some patients take this medication is primarily hypertriglyceridemia or high triglycerides. Some contraindications for this medication include severe kidney, liver, or gallbladder disease. Why is that? Well, 70% of the secreted, 70% of it is secreted by the kidneys, and some metabolized by the liver. And in addition, there's an increase of incidence of gallstones or cholelithiasis due to the increased cholesterol excretion into the bile. That's why those are the contraindications. Some nursing actions. So it is very important that we check or follow or analyze our lipid panel. So what does that include? You have your total cholesterol, your HDL, your LDL, and all those things. So again, it includes also your triglycerides. In addition, it can affect coagulation. So it is also important to check your coagulation testing or coagulation tests. So which ones are the coagulation tests? So you have your PT, PTT, and INR. So in addition, because we know that it can affect coagulation or clotting, then we need to also observe or analyze or look for possible signs and symptoms of bleeding. So that will include a decrease in H&H or hemoglobin and hematocrit, which shows some anemia. So again, the increased levels or high levels of this medication can put the patient at risk for bleeding, especially if the patient is taking warfarin, which is a blood thinner or anticoagulant. Examples of drugs in this class. So the one that you have to remember is gemfibrozil or Lopid. So gemfibrozil is your generic, and that's what you have to remember. Cholesterol absorption inhibitors. So cholesterol absorption inhibitor The mechanism of action is basically it blocks the absorption of cholesterol in the small intestine. So what is the therapeutic effect? This generally lowers the total cholesterol. So this is not a very specific lowering agent. So this generally lowers the total. So it's not specific for just LDL, HDL, or triglyceride, unlike the other ones that are a little bit more focused on one type of cholesterol. So this decreases the total cholesterol. What are the contraindications for cholesterol absorption inhibitors? Just like your statin, this is contraindicated in pregnant women. So this is considered a pregnancy category X, and as well as liver disease. So examples of drugs in this class is Zetia or ezetimibe. Ezetimibe is your generic name, therefore you have to remember this. Next thing that you have to remember is your platelet aggregation inhibitor or platelet aggregation inhibitors or antiplatelet agents. So what is the therapeutic effect? So from the name itself, right, from the form class itself, it inhibits, right, platelet aggregation. So it prevents, right, inhibit platelet aggregation means sticking. So it stops the platelet that are responsible for clotting from sticking together. Indications or reasons why patients are on antiplatelets or platelet aggregation inhibitors include CAD, right, coronary artery disease, myocardial infarction or MI, and thrombotic stroke. Some contraindications or reason why we shouldn't give antiplatelet agents to certain patients. Well, one is active bleeding, including GI ulcer, right, and a recent hemorrhagic stroke. So obviously, we're preventing clots from forming, but if you have somebody who's bleeding, then we don't want to give this medication. Also, patients with GI ulcer, they're already at risk of developing bleeding, right? And also, recent hemorrhagic stroke. We don't want that stroke to even grow bigger or for the patient to develop another hemorrhagic stroke. And next is thrombocytopenia or low platelets. So if the patient already has very low platelet, right, and then we try to give them antiplatelet agents, then that actually puts them at higher risk for bleeding, because with the limited number of platelets that they already have, the function of those platelets is not going to be the same, right? It's not going to be as effective in hopefully producing clots when it comes to injuries. So this is contraindicated for patients with low platelet levels or thrombocytopenia. So side effects of these medications, right, for the antiplatelet, obviously active bleeding. It can be either obvious, right, or occult or hidden. So something that may not be as obvious, such as you don't see any bright red blood coming out anywhere, right? And then another side effect is thrombocytopenia. That's why thrombocytopenia is included, because it can actually worsen the platelet levels. It can actually make it even lower. And one is GI upset. So nursing actions or nursing interventions when somebody is on antiplatelets or platelet aggregation inhibitors. Obviously, we need to monitor for bleeding, right? Again, either obvious or occult. Also, we need to analyze our labs, including your CBC, right? Your complete blood count, your hemoglobin and hematocrit, as well as your platelets. And definitely patient education. We need to educate our patient regarding the drug, right? What it is, what's the use, what are the side effects, what are the signs and symptoms of bleeding, so they know what to report. And also any possible interactions, right? So let's say this patient is on the on a fibrate, and we know that the side effect of fibrate is actually it can increase or the risk for bleeding, then we may need to let them know that this medication in combination to the fibrate can put them at more risk for bleeding. There may be an interaction, and that may be something that they need to clarify with their provider and see if there's another agent that they can use to prevent them from developing those adverse reactions. Examples of drugs in this class, so the drugs that you need to remember under platelet aggregation inhibitors or antiplatelet agents include your aspirin, or it's also written as ASA, and the pharm class of this, although it is also considered a platelet aggregation inhibitor, right? The pharm class of this is also salicylate or salicylate. You also have Plavix or clopidogrel. So this is an antiplatelet agent. So antiplatelet is actually the therapeutic class, right? And its pharmacological class is platelet aggregation inhibitor. All right, next we're going to be talking about angina or chest pain. So we have the stable angina pectoris, there's also prinzmetal or variant angina, and there is unstable angina. So what are the differences? So what is stable angina, what's prinzmetal or variant angina, and what's unstable angina? So stable angina pectoris, or basically from the name itself, it's stable. So this type of chest pain is usually temporary, it's reversible, and usually it has a pattern, it has a trigger. Most patients, especially if they've had it for quite some time, they know what triggers it. They know what activities can cause them to have chest pain. And most of the time, as long as they stop that activity or that thing that's triggering them to have a chest pain, it actually stops. So it is very temporary and definitely reversible. The most common reasons why these patients with stable angina develop chest pain is usually induced by smoking, exercise, substimulants such as cocaine, and sometimes anemia. Now, prinzmetal or variant angina, on the other hand, is also known as a vasospastic angina. So this is actually caused by coronary artery spasming. So they're narrowing down, and basically it's narrowing down, right? It's causing some spasm, and usually it's either from the cold weather, right, or from stress. So it's caused by vasospasm, but when it's prolonged, right, if the coronary arteries are vasospasming for a longer period of time, this one, unlike the stable angina that's reversible, this may actually cause some ischemia, right, or some sort of an injury to the heart muscles. And this kind of diagnosis, I don't know if you guys can remember from unit 3 part 1, it can be related to very similar to how migraines happen, right, and Raynaud's. Therefore, because of that similarity or vasospasm, the treatment is quite similar. So we treat it with calcium channel blockers, right, because it prevents the vessels from spasming. And so again, the first line treatment for this kind of chest pain is actually calcium channel blockers and nitrates. And last but not the least, we have unstable anginas, right? So unstable angina, from the name itself, it's unstable. So this kind of chest pain is usually it usually increases over time. The pain intensity increases, and it's mainly due to coronary artery atherosclerosis. So atherosclerosis is the hardening of the vessels, and from years, and usually years of cumulative damage from whatever other medical history that the patient has, and also from plaque, right, from the plaque buildup from the cholesterol, and it can also be from plaque rupture. And usually this unstable angina, right, this kind of chest pain, it's usually when it first starts, it's very intense. And this one, it can occur at rest, and it's unpredictable, unlike your stable angina, right? The stable angina, most patients know when it's going to happen. There's a certain activity that is tied to those symptoms, and once that activity stops, the chest pain stops. While in here, unstable angina, the pain doesn't really matter what the patient is doing, right? They can be sleeping and everything, but they can still experience that severe, excruciating chest pain. So how do we treat unstable angina? So we have the emergent treatment for chest pain or unstable angina. So the acronym to remember is MONA. So MONA stands for morphine. So M for morphine, O for oxygen, N for nitrate, and A for aspirin. So morphine, as we know, it's an opioid, it's a narcotic, it's a drug of choice because it actually lowers the myocardial oxygen demand, it decreases the pain, and it decreases anxiety. Now we have to be very careful because of how it works. The side effects of morphine can include low blood pressure and decreased respiratory rate. Now oxygen, it's a pretty given. We just give oxygen supplementation. And nitrate, it's used for vasodilation, right? So if you have some vessels that are narrowed down, when you give nitrate, vasodilation, it opens those vessels. So examples of those medication include nitroglycerin tablet sublingual. one thing to remember is that nitrates are very potent vasodilators, so it can cause a drop in blood pressure, and it is also associated with headaches. So make sure you're assessing your patient, making sure that their blood pressure didn't drop, right? So you measure your blood pressure before and then after you give it, as well as assess for any development of headaches. Sometimes you can just tell the patient that the headache can be temporary. It usually gets better over time. Sometimes it's just when they just newly are started on this medication. But also, if it's not tolerable, maybe we need to coordinate and collaborate with the doctor and see if there's something else that we can give for this patient. Lastly, we have aspirin. So again, as we discussed earlier, aspirin is a platelet aggregation inhibitor, but it's also categorized under the pharm class salicylates. This is a non-steroidal anti-inflammatory drug. So after the emergent treatment, right, and the patient is experiencing the same thing, the chest pain is not going away, then we have a continued treatment for chest pain, right? So we're still giving pain management, morphine, right, as needed for pain. And then we'll also continue to give, we will also continue to give vasodilators, mainly nitrates. Nitrates include nitroglycerin tablet. And something to remember is that sometimes in the hospital setting, you don't only have your tablet, the sublingual tablet, you can also see Nitroder, which is a transdermal patch, and you also have Nitrobid, which is an ointment. So just remember, look at what kind of medication they're on, and if they're the patches, right, or the ointment, make sure you remove the old one before applying the new ones, right? Because you don't want to overdose your patient either. And also make sure that you're not touching it yourself, because it can actually lower your own blood pressure. So if you're touching it, you don't have any gloves, or it sticks to you accidentally, you may actually experience the effects and side effects of that medication. So be very careful when administering nitrates. Again, continuing treatment with a platelet aggregation inhibitor, mainly aspirin. You also have your beta blockers. So some beta blockers are your atenolol and metoprolol, right? Those are your cardioselective beta blockers. But you can also give propranolol, which is your non-selective beta blocker. So just remember, all three can cause bradycardia. So make sure you're teaching the patient that they have to measure or check their pulse before and maybe after taking the medication, right? So you as a nurse too, if they're in the hospital setting, you have to make sure that you check that before and after and make sure it's documented. So that's really just protecting you. Next, you have calcium channel blockers. So calcium channel blockers, you have amlodipine and diltiazem. So unfortunately, right, so if we continue to give all these treatments, some patients don't feel much better over time for some reason. There may be something else going on that needs a different intervention rather than just pharmacological intervention. So usually, if the chest pain continues, right, and the doctors are concerned, the providers are concerned, the next likely intervention is cardiac intervention. So mainly percutaneous coronary intervention, or PCI. And sometimes if that doesn't happen, then possibly surgery. So mainly open heart surgery or CABG, coronary artery bypass graft. So PCI, angioplasty, this procedure, basically they use a catheter to place a stent to actually open the vessels. So, and usually that usually is effective for some patients, right? But sometimes when the disease is quite severe and this is not effective, then again, that's when they consider surgery. So next is myocardial infarction. So basically when the ischemia, when the injury continues, right, and that prolonged ischemia or lack of enough perfusion or blood supply in that area, it can cause irreversible cell death. So that's what you call infarction, right? The death of the cell. So in this case, myocardial infarction, the cell, right, the myocardial cells in certain areas are dead, right? So we can't really undo the damage at that point. So signs and symptoms of MI or myocardial infarction includes intractable chest pain. So this is the way sometimes they would describe it is this is the worst chest pain that they've ever experienced. It feels like an elephant sitting on their chest. This chest pain is hard to deal with, right? It's too much, and it's unrelieved by rest. So resting doesn't do anything. Oxygen, morphine, so your MONA is not effective. So whenever you give all those intervention and the patient continues to experience that chest pain, you need to start being concerned, right? Start asking yourself, is my patient experiencing an MI or a heart attack, right? And so sometimes the description and the location can change a little bit depending on who is describing it. And as some of you may know, that some women may actually not describe it the way that men would describe it. So for men, it's a little bit more straightforward. For some women, they can actually say, "Oh, I think I'm having a jaw pain, or my back is hurting." So it's an atypical type of chest pain for certain population. So next is complications. So complications from an MI. So this list is not inclusive, so it doesn't include everything that can happen, right? But these are the things that you need to know for your course and maybe to practice in general. So these are the common things that you may actually see when a patient develops myocardial infarction. They can also develop these complications. So one is dysrhythmia. So anytime you're disrupting your heart cells, right, it can put the patient at risk of developing dysrhythmias. Pericarditis. So this is the inflammation or swelling of the lining, the pericardium lining or membrane of the heart, right? So it's a common inflammatory response from an injury. So this can happen, which can actually worsen the symptoms, right? Because this is also causing chest pain. And in addition, it can lead to heart failure and at worst, cardiogenic shock. So cardiogenic shock is really the pump failure. Your heart can no longer pump enough blood to meet your body's demand. So the way to determine this is basically a lot of the times your heart can no longer maintain an adequate blood pressure. So you will see low blood pressure in this type of patients. And sometimes they need extra medications to increase the blood pressure. But even after that, they struggle to keep that blood pressure, to keep that blood flow, because the heart is already, basically, the heart is damaged enough that it's already not functioning correctly. So it's not pumping enough. It's too weak. All right. So general treatment when a patient has a myocardial infarction. Obviously, we have to provide oxygen, right? So oxygen supplementation and control the electrolytes. So we need to monitor, right? Analyze and control or replace those electrolytes. The most importantly, right? The most important electrolytes in cardiac patients that you have to monitor and ensure that they're at the right level are two. Remember this, your potassium and your magnesium, because that electrolyte disruption, right? If we don't control that, it can lead to cardiac dysrhythmias again. So next step, right, for general treatment, we need to control those dysrhythmias, and a way to prevent those dysrhythmias is controlling your electrolytes. So controlling dysrhythmias, giving antidysrhythmic medications if needed, and again, patient education, making sure that they know when to go to the hospital, when to call 911, right? That time is essential when it comes to this. So even if they're not very sure about the cause of chest pain, it's always better to tell them to go to the hospital so we're not wasting time. Because again, time is muscle cell, right? That's equivalent to the life of that muscle cell, to preserving that heart function. So we need to make sure that we give them that information as well as treatment, psychosocial support, and follow-up, and so on. All right, so how do we treat MI? So pharmacologically, we treat MI by treating the acute pain. So acute pain management, we use morphine, right? We also use vasodilators. Primarily, we use nitrates, right? Nitroglycerin. Then we also have platelet aggregation inhibitors. Example of platelet aggregation inhibitor is your aspirin and clopidogrel. You also have beta blockers, right? Because they decrease the myocardial oxygen demand. It decreases the heart rate, the afterload, the BP. It also decreases the contractility. Therefore, it improves patient outcomes. Examples of beta blockers are atenolol, metoprolol, and propranolol. Next, we also use calcium channel blockers, right? Calcium channel blockers, similar to the beta blockers, they decrease the myocardial oxygen demand and decreases heart rate, decreases blood pressure, decreases contractility, and it causes smooth muscle relaxation, right? Especially if the patient is experiencing coronary artery vasospasms. So examples of these drugs include amlodipine and diltiazem. Next, we're going to talk about anticoagulants. So what is the thing to remember when it comes to their mechanism of action? So you have to remember that they exert action in clotting cascade. So it has no effect on clot that's actually formed. So it doesn't break down existing clots. It just prevents clot from forming, right? Or maybe even getting bigger or worse, right? But if the clot is already there, it doesn't melt it, it doesn't break it apart. So from the mechanism of action itself, right, therapeutic effect would be it prevents clots from forming. So this is an antithrombotic. Indications for anticoagulants. So reasons why some patients are on anticoagulants. An acronym to remember is CHP-HD. CHP-HD, basically CAD, MI, heart failure, heart valve replacement, pulmonary embolus prophylaxis or treatment, history of thrombotic stroke, and DVT prophylaxis and treatment. Contraindications are reasons why we shouldn't be giving anticoagulants to this patient. So one, pregnancy depending on agent, right? So usually enoxaparin or Lovenox is okay to give, right, with precaution to pregnant women. But the other ones are not. And also, obviously, right, anyone with active bleeding, we're not supposed to give anticoagulants when a patient is having active bleeding. So whether it's visible, right, if we can see like the obvious blood coming out, or even occult if it's internally. So either way, this is a contraindication. Now, sometimes you see in the hospitals, the doctors will have to weigh the benefits versus the risk. If, let's say, somebody's having a heart attack, but they also have a small GI bleed, then they may have to kind of weigh in, and sometimes they may need to get the patient involved. So as long as they know, what's going on, and together they can develop a care plan on how to really attack this problem. But in general, right, if somebody has any sort of active bleeding, this is contraindicated. So side effect, an acronym that makes it easier for me to remember is TBHN, or to be honest, no, right? So this side effects, to be honest, no. So T stands for thrombocytopenia, B for bleeding, H for hypotension and dysrhythmia, and N for nausea and vomiting. So examples of drugs in this class, so these drugs that you have to remember under this class, so under anticoagulants, you have Coumadin or warfarin. So Coumadin or warfarin, its pharmacological class is coumarin derivative. So its therapeutic class is actually anticoagulant, but its pharm class is coumarin derivative. So this specific medication, we adjust the dose based on the PT and INR. So PT is basically how long it takes for the blood clot to form. You have to remember the reversal agent of this drug. So the reversal agent for this drug is vitamin K. So if you have somebody on Coumadin, right, and for some reason, maybe their levels are too high and they're at very high risk of bleeding, and you have to give a reversal agent to basically reverse those effects, the drug to give is vitamin K. And how I remember it is vitamin K, although Coumadin starts with a C, Coumadin or warfarin, I just think of it as Coumadin starting with a K. I don't know if that makes sense, but hopefully it helps you guys remember this medication. Next drug is heparin. So heparin, it's pharmacological and therapeutic class. They're both anticoagulant. So it has the same pharm class and therapeutic class. So this medication is given sub-Q and IV. And When it comes to the sub-Q, usually there is a very standard set dose, while when it comes to IV medication, so when we're giving it as an IV infusion, this medication is dosed based on the PTT. So PTT is a blood work that we use to monitor for the effectiveness. So PTT stands for partial thromboplastic time, which is basically a measurement of the intrinsic coagulation pathway. So again, the IV dosages are based on PTT. The reversal agent for this drug, so the reversal agent for heparin is protamine sulfate. So this medication actually binds to heparin and neutralizes it, therefore lowering or blocking the effect of heparin. So the reversal agent for heparin is protamine sulfate. Next is Lovenox or enoxaparin. The pharmacological class of Lovenox or enoxaparin is low molecular weight heparin. The therapeutic class of enoxaparin is anticoagulant. The reversal agent is actually the same for enoxaparin and heparin. So they both, we can both use protamine sulfate to reverse this medication. So next is fibrinolytics or thrombolytics. Fibrinolytics or thrombolytics are different compared to anticoagulants, although I know a lot of people actually get confused on which one is which, right? So anticoagulants prevents clots from forming. Meanwhile, fibrinolytics or thrombolytics actually breaks down clots. So that's definitely a completely different therapeutic effect. So fibrinolytic breaks down, lyses clots. Indications or reasons why patients are put on thrombolytics or fibrinolytics. So one is the presence of MI with a specific criteria. So they have to meet certain criteria, but in general, somebody with an MI or myocardial infarction, a thrombotic stroke within a certain criteria as well, and DVT as well as PE. So DVT is deep vein thrombosis, PE is pulmonary embolism. So DVT is basically clot formed somewhere in the deep veins, and the common site is usually on the legs. Also, PE is also clot formed, but usually the clot is formed somewhere else, and then it goes all the way to, it travels basically to the lungs. So that's what PE or pulmonary embolism is. Contraindications for fibrinolytic or thrombolytic use. So this is pretty straightforward, right? So this breaks down clots, right? It can cause bleeding. Therefore, contraindication is actually active bleeding. So anyone with active bleeding, so again, either it's obvious or not, visible or not, this is a contraindication. Because again, the most common side effect of this drug is bleeding. So we don't want somebody who's already bleeding to bleed even more. So we will cover the rest of these topics on another video or video lecture recording. So just be on standby, just wait for it to post. I will try to post it as soon as I can. Thank you.